Good morning. My name's Leanne Harling and I'm here today with Professor Martin Elliott to talk about advances in tracheal surgery and his experience of the tracheal service and sliding tracheoplasty. Professor Elliott, good morning. I'm very pleased to sit and have a chat with you today about such an interesting topic and something that you have a vast experience with. So I thought perhaps we could start by just talking about your setting up of the UK National Tracheal Service and how it came about and what the key factors involved were, really.
The first part of it follows the way management of these kids was in the 80s and 90s, which was ad hoc, largely in individual cardiothoracic units and some ENT units. And the results weren't very good. The operations weren't organised. Everybody did their own thing. The literature was beset by case reports, so you had the usual stuff of publishing 6 patients and aren't I wonderful, sort of stamp collecting papers. But there didn't seem to be much aggressive thought going into it. And of course, Hermes Grillo had been working in Boston. There were lots of things going on, and individual operations looked quite attractive. So the operation that was most commonly done in the 80s and 90s was a patch tracheoplasty using pericardium, usually. All the heterogeneous material and plastic material had all failed. And towards 2000, I thought we needed to rethink all this and formed a team based from all of the people who were doing this work: ENT, interventional radiology, intensivists, anaesthetists, respiratory physicians, nurses, everyone who'd looked after a patient came to a single meeting. And before that, it had been just consultation. It was very inefficient. Sometimes getting a bronchoscopy done, you'd have to wait for 2-3 days for someone with the right experience to do it. That was hopeless for patients. Anyway, we got together, and I'd already started doing some slide tracheoplasties, and they just seemed to behave differently. It had first been described by Victor Tsang, who I came to work with at GOS, with Peter Goldstraw at the Brompton, but it was a really short segment slide. And our experience of doing extensive slides in the aorta made you think, well, if we mobilize this stuff, it's going to be easy. And so we did it, and we found we could do the whole trachea, actually, from right down into a bronchus, from the cricoid into a bronchus. And that discovery meant that all the long segments suddenly opened up as being potentially treatable. And most of them had a congenital heart anomaly, usually PA sling, so it was sensible to do it in our place. And very quickly the team worked well. I mean, we all got on well. It was self-selecting in a way. And we managed to reduce the cost and increase the efficiency, reduce the complication rate. And very quickly the results got better. So we said, can we have some money and form a national unit so we can even more increase the volume we did. I remain convinced that the more you do, the better you get. We all got on quite well, and we managed to get improved results very quickly. And so the next phase was to see if we could bring in some more resources and increase the quality even faster. And we felt we needed to be bigger to do that. And so applied for some money to become the national centre, and that not straightforward. You know how bureaucracies work. Well, lots of bidding and lots of evidence, and also a bit of opposition from other centres that we gradually resolved by incorporating them into shared care contracts. And we grew really quickly, and the number of cases that we do now has continued to grow from 2006. It's still going up each year, with referral from all over the world, and particularly from Northern Europe, although after Brexit, who knows what will happen. And just as we expected, the more we did, the better we got. And we were able to develop a whole bunch of new treatments as well. Maybe the most important one is a massive use of fibre optic endoscopy, the microscopes, the 2.2 scopes, and training lots of the staff to do that. So it wasn't skills that we hung on to ourselves because we're clever doctors. We trained the radiographer to do it, and she now does more than anybody else and does it better. We started first of all to put stents in there, which people were arguing against, and they've also done quite well long term, and now developed absorbable stents, which are working quite well. And balloon dilatation, radial balloon dilatation, done by IR and not by us or by the ENT surgeons has changed the outlook for these kids. So gradually the quality of life has hugely improved, and the survival is now well over 90%. And the mortality usually comes from associated severe cardiac disease or multiple other congenital anomalies. It's a different world.
Yeah. And to talk a little bit about the problem of long segment tracheal stenosis, how prevalent in your practice? I mean, was it the main tracheal pathology that you found yourself dealing with through the MDTs?
Yeah, it was to start with. But then you kind of open a door to all the other crap that nobody wants to deal with, and that was a real eye-opener to us, that there were a whole bunch of people out there, for example, with severe tracheomalacia, primary or secondary tracheomalacia, that nobody seemed to be able to manage, or kids ending up with a tracheostomy that didn't need to. So there were a lot of post-tracheoesophageal fistula patients, for example, who were arriving with a tracheostomy or were being seen in clinics over and over again, people not being sure what to do, stuck on an ICU on a ventilator. And so we started to do a lot of aortopexies, which again altered the outcome for most of these children, and now hopefully there'll be some more proper randomized trials of that therapy in due course for the anterior approach, which we used for small median stenotomy. Some people did a small lateral approach, and now endoscopic approaches as well. So we'll wait and see which one of those works, but the results were good for a while. And now it's battery trauma that really is opening up a huge amount of problems. Those little button batteries that you get in these microphones and other things that kids just love to eat. Yeah. And when they're fresh, those batteries are really dangerous. And they erode through the esophagus and then out into the trachea and create really destructive lesions. So we've then had to work out ways of fixing that, which is a sort of primary first aid repair. Deal with the esophagus, deal with the trachea. And sometimes that leads you into say, what happens when all of this stuff you've done goes wrong? The slide tracheoplasty doesn't work, the patch tracheoplasty doesn't work, the stent erodes into an aorta, the battery is an irreparable lesion in the trachea. And that raises the whole question of, can we replace the trachea? So that the latest part of the work from 2000 onwards as well was, can we replace the trachea? The exam question. And we started off using homograft patches, bits of aorta for a while, and then ended up in an individual patient going for a stem cell supported transplant, which has proved to be both effective in him and highly controversial, as we might discuss if there's time.
Yeah, absolutely. We'll take it back a little bit to the sort of technical aspects, because I know there are quite a few people who want to know your tips and tricks how to get such good outcomes. And I suspect a lot of it is surrounding your role in multidisciplinary management of the patients and perioperative care. Can you tell us a little bit about the surgical side of things? So at what point is a primary resection and reanastomosis of the trachea not successful? At what point would you describe a long segment would require something like a sliding tracheoplasty? What's your cutoff?
So there are a whole number of variables you've put into one question there. The first is what else is going on in the chest, so what are the other congenital heart anomalies? And the second is how big is this baby, and how big is the trachea in terms of length and transverse diameter? And what else have you got to deal with? So this kid may arrive on ECMO, for example, if the tracheal transverse diameter is less than a millimetre, as it sometimes is. But I don't think there's any virgin trachea that can't be slid over its whole length. I've never faced that problem of not being able to do it. There are a whole bunch of variants of the anatomy which we haven't got time in this interview to discuss, but we've published about. But the first is you have to do your dissection quite close to the trachea, separating the recurrent laryngeals so they're clear. And you can do that with just blunt dissection with forceps, using them with forceps quite often, a little touch with a diathermy. It really helps if you divide the thyroid isthmus in the midline. Don't ask me why, I've never really understood why, but you get about a good ½ centimetre of length. We used to do a hyoid release to drop the upper end, but that is not very good and it can disturb swallowing and speech a little. So dividing the thyroid isthmus in the midline is really good. look for the recurrence but don't damage them. And then at the lower end, you want to free up the posterior pericardial reflection and any adventitial tissue that goes down into both bronchus. And suddenly you've got an enormous amount that you can bring up. If you're really stuck distally, then you can open both pleura and release the pleural reflection around the hilum and tease that apart, and suddenly you sort of exvaginate the hilum into the chest, and you get a little more proximal anastomosis. But I haven't had to do that for 10 years, I don't think. The thyroidismus was the little extra trick. Then the next hard choice is, where do you make your cuts? So you'd think it would be easier to, well, it is easier to cut up the front of the upper end and down the back of the lower end, slide them together that way. But actually that makes the trachea not very attractive if you ever need to do a tracheostomy. So I think it's better to make your incision posteriorly on the upper end and anteriorly on the lower end, and then slide them together. What's about suturing? Was that enough? Have you done enough dissection?
Well, we can talk about suturing. I mean, suture materials have evolved over time. I'm sure you've seen.
So we had we've always used absorbable sutures of monofilament PDS, but there was a vogue for using continuous sutures, and our only dehiscences came when we did that.
Right.
So we went back to using almost entirely interrupted sutures with 3 at the top first and 3 at the bottom. Which are then tightened, tightening the middle one last, because that's where the trachealis is, and that will cut through. So you have to tie the other 2 first, and that gives you something to anchor to. And then if you do the same at the lower end, and then put your interrupted everting sutures all down the side, you'll end up with a nice non-figure of 8 trachea on the inside.
And from reading your excellent results that were published not that long ago, actually, quite a large series. I know you've dealt with a broad spectrum of patients, from neonates to actually slightly older children.
To adults as well. Yeah.
Do you find that the technical challenges change as the patient gets bigger?
It gets a bit harder when they're bigger, and it gets much harder if they've had previous surgery.
Yeah, absolutely.
Not impossible, I should say, but it's harder, and it's harder to identify stuff, particularly the recurrent laryngeals, which is a worry. I think that there's a few things that you should avoid when you're running this sort of service. Try to tell people not to do a tracheostomy before they send the patient, because that makes it much harder. And all the associated cardiac defects and congenital anomalies really complicate your decision making. And we've looked and published about the risk factors that are associated with that. But it wouldn't put me off reoperating. Doing a second slide tracheoplasty should not be necessary. And it's usually only been necessary in my experience, fortunately not in our place, but in others, where I've been called in afterwards, because people have missed a complete ring. Usually I forgot to mention that, they nearly all have complete cartilaginous rings all the way down the trachea. So if you miss one, then the stenosis doesn't go away. And you can cut it with a laser or an aggressive balloon, but it's not as good as getting your operation right first time. So the second thing to say technically is assess it in theatre, and don't leave the operating theatre till you've checked with a bronchoscopy. What
are the key points of intraoperative assessment when you're actually physically looking at it? Because obviously you've done your pre-operative. Yeah, pre-operatively I'm not so worried. It's post-operative. Once you've finished your slide, you're still on bypass, so you can put the scope down and have a really careful look round and suck out any blood that's got in, which is quite important. And if you can get the bronchus completely clean and see in and out, you can feel fairly relaxed. It's going to be all right. And then using the scope, we can position the endotracheal tube in the middle of the repair, which means that you then can start your ventilation in a very good way. And with regards to sort of management of these patients in the early post-operative period, obviously the procedures are performed on bypass. Do you how do you manage them acutely in the first sort of 12 to 24 hours? At what point?
It's nearly always the easiest time if you've done it well.
Okay.
If it's not, you need to investigate whether you've got a problem with your airway, and that would be doing a bronchoscopy or a bronchogram. Bronchography, which is not very trendy in the United States, has really helped us an enormous amount because it gives you dynamic information about the airway and is very easy to do and can be done in the IR suite really well. So we use fibre optic endoscopy in the ICU, and if we need more imaging, they get a bronchoscopy and a bronchogram down in the IR. So the first thing is to look if you've got a problem. Don't ignore it. And if you then have a narrow airway or a twisted airway or something, fix it. Go back. Don't put it off. The cardiac stuff usually in those first 24, 48 hours is the bigger problem, to be honest. I think we got good enough at the repair to feel more confident. I mean, I've stopped doing them because I'm so old, but my successor, Nagarajan Mutialo, is a fantastic surgeon. He's doing, an enormous number of these. I think we're up to 150 or 160 is a paper about to come out. So it's those early stages. Teamwork again. If the intensivist is unhappy, just ask why. Get together, sit around a table, ask why. What's it Toyota say? 5 whys will always get your children probably tell you the same thing. But you nearly always get to the bottom if you just keep asking why. Don't ignore it.
Yeah. And we talked a little bit about new novel technologies and the potential for tracheal replacement. I know it's a very contentious issue and something that's been highly publicised in the media as well. There's been recent publications, certainly in adults, about aortic homograft replacement, stented aortic homograft replacement of the trachea. Do you think that that's something, I mean, are we just going around in a big circle again? Or is this something that is a newer development that you think with novel technologies might be then more adapted into children as well?
So we're faced with a slight problem. There aren't enough patients who need this to answer that. And the animal work it's quite difficult to find a good animal model which parallels children with tracheal stenosis or people with complex tracheal problems. And so that you end up with patients who need something done before the science is ready. And so I think you have to look at this work in 2 ways. One, if faced with a compassionate use decision, I need to replace this person's trachea, what am I going to use? And secondly, what science would I do if I had the money to do it? So the compassionate use thing is always going to be dependent on the literature that's available at the time and who and what you can get hold of. So we used homographs for a long time and then couldn't get them because of the BSE crisis and the prion anxieties. So when we needed to replace a trachea, we went to what at the time seemed to be the procedure of choice, which was a stem cell supported graft which had been used for Claudio Castillo in Barcelona. And it seems that the person who was proposing that was basically publishing data which were unsustainable and went on to do the same in secondary trials using the synthetic trachea. We've all been very damaged by that. I feel quite strongly about it. I think the message from that is something which our world can learn hugely, is that no paper should be accepted in any medical journal without the raw data being made available. Full stop. And that the data set which is associated with that procedure, especially a new procedure, should be held publicly with fixed data definitions, and no second person should be allowed to do that procedure unless they submit data to the same place. And no patient should have it unless they also agree that those data should go to the same place. Otherwise we'll never make any progress on those compassionate use small population studies that beset our field. On the science side, I think that there needs to be continued work on the use of the aorta, which seems attractive, but there could easily be problems with late calcification, which we haven't addressed. We need to know how well that epithelial functions long term. We need to look at a sweep of mucus up that trachea, because is the epithelium organized? There's lots of research questions. Pierre Delaire's approach of putting a inverted donor trachea in the forearm and using partial immunosuppression to make tolerance requires further work, and I would say the entire field of stem cell regenerative supported trachea is still wide open, and I'm not going to say that I don't think it's viable. It's just that the evidence is weak at the moment. And we've got 2 survivors out of 3 using that technique, but that doesn't mean it's any good. But 2 survivors out of 3 was the same as the Norwood in the first days. So, you know, and the progress didn't come from doing that same operation, it came from changing the way we did things. So, I mean, compassionate use, research, get the research right. You will always be feeding back to compassionate use. The compassionate use will always be controversial. But that's why we do the research, for patients.
It all feeds back into your original concept of the whole multidisciplinary team and everybody being as a group decision rather than a single individual.
Yes. I mean, even the stem cell work, we tried, after it became controversial, to organise an international consensus statement, which we did. We got together in Paris, but the 2 big controversial people in it were basically fighting each other, and one of them wouldn't come. I mean, what can you do?
Lots of type A personalities in the specialty. I think it also makes it a little bit difficult. And as you said, us learning to teach others and to give away little bits so that we can progress other bits, I think is really fundamental.
Yeah, I mean, I've said this before, but it seems to me also important that people are aware that what they're doing is risky, and that on occasions you have to take risks, but you need to share those risks with the family, not be secret, not lie. And they need to be written down explicitly and approved by all the ethics committees you can get your hands on, and get that criticism before you do anything stupid, not afterwards. It's much better if you can build that consensus with the whole team, because the family, in this context, are taking part in an experiment, and they are the only people who can suffer in the experiment. So you building their confidence and consent and sharing the entire data set with them in a way that they can understand is critical.
Absolutely. Thank you very much. I think we probably have to end it there, otherwise we could talk all day, I'm sure. Thank you very much for sharing your experience with us and for giving us another inspiring talk. Thank you.